I'm going to do this without any slides, and just to try to give you an idea from a standpoint of running a large healthcare company, what we do with hospital design, what we see going on, not just in the United States, but all around the world. You know, first of all, if you look at the United States, there are just an unbelievable amount of money right now going into new construction for hospitals. And so at GE Healthcare, we're often dragged into those hospitals because they're asking us, Joe, we're building 10, 20, 30, 50 years into the future. What's the technology going to look like? You know, how do we have to make room for it? What's the footprint going to be? How will it change healthcare in some way? And so we started a business called Performance Solutions, and a branch of it that was able to address those questions. What we quickly found is often it wasn't a question about what kind of technology, specifically a new cath lab or how a CT would work or a monitoring system. We found out a lot of it had to do with 5 variables that I'll walk you through very quickly. The first one has to do with how do you really drive clinical workflow? And I know this isn't exciting, it's not about robotics or anything like that, but some of the hospitals that are being built today, you think about what's the bed capacity. But if you go to Calgary, Canada right now, or if you go to Arizona, which are 2 of the biggest building sites, you'll see beds lie empty today because they can't find enough clinicians to be able to service those beds. And so the trick is to truly understand workflow in those areas, and to remember, in that part of the hospital, you're paying 75 to 80% a day of your expenses a year are going toward those variable costs to clinicians. So you have to make that as efficient as possible. So we've done a lot with Toyota lean processes to understand workflow, to map different processes, so you can make those clinicians as efficient as possible. So the first thing is understanding that is not building how many beds, but how many beds you can profitably and practically service in that end. So that clinical workflow piece becomes very important. Secondly, information technology today and in the future will have a huge impact on the hospital of the future. And often, again, we have about a $1.5 billion information technology business within GE Healthcare. And so we do everything from the enterprise side all the way to application software, it would be in cardiology and radiology in those areas. And we often think about how that technology is confined to those 4 walls of a hospital. But in the hospital of the future, it has to do with how you can move that technology out and take advantage of things in 2 ways. How do you embrace the primary care physician office place? How do you look at the home marketplace? Because more and more patients are going to be in their homes, and how do you, where they would have been in a hospital before, how do you actually service them in the home, monitor them in home in some way? And the last thing is on the IT side, you're constantly asked about how you wire this and how it works together, but you need a brain. You need to be able to think about computer-aided diagnostics. You have these unbelievable amount of information. You have to have the kind of algorithm that you can run against that and pull out pertinent information about your patient base and how things go. So the brain of that system is truly important, not just how it's wired and how it's embraced. You know, thirdly, at GE Healthcare, we talk a lot about early health and what that'll mean in the hospital of the future. And so if you can actually catch disease earlier and be able to manage it earlier, it'll change the configuration of your hospital pretty substantially, because you're going to have sicker and sicker patients probably in those hospitals over time, because you identify things diagnostically up front. Hopefully you deal with it in a reasonable way, maybe in a minimally invasive way that wouldn't even be within a normal hospital, it would be in an outpatient imaging center, and you work with it then. So you have to think of the boundaries of the hospital, not again being in those 4 walls as the classic definition, but how do you expand outside of that as the technology for early health and diagnostics allows you to do that. On the flip side of that, and this is the 4th point, many of these patients will be extremely elderly patients. As I go out there and I talk to hospital administrators today, they say, Joe, we discharge people today that we would have in the intensive care unit 10 years ago. These people are going home in that kind of condition. And that's just the way reimbursements work today. It's also practically how technology can work to be able to monitor those patients and bring them back in the hospital as it's needed. So again, the hospital of the future has to reach out and embrace those patients who will be very sick when they're discharged, and make sure that you can anticipate their needs and work with them so they're not necessarily coming back to the hospital all the time to be serviced, because it's a real burden on the hospital and a real burden from a payer standpoint to do that. The last piece I'll give you in the 5th point is I think green and environmental is going to have to be, it's something that's considered in the hospital of the future in a huge way. Is when you do the work on hospital of the future, it uses about 2.5 times the carbon footprint of a commercial building that sits right next to it. 8 times the water, right? There's 2 million tons of waste generated by U.S. hospitals every year. Now, that's not because hospitals are sloppy, it's because they're doing the job that they have to do. But I think as being part of the whole socioeconomic system of cities and different municipalities, you're going to have to think about that more as you think about your environmental footprint. There's things that we all can do collectively with technology today, but we have to think about how that would work. So lastly, what I'll share with you as I was putting this together, I obviously I'm a business person that it's kind of a doctor because I go to the Holiday Inn Express at night, okay? But when I walk into a bank, an old bank, right? You know what I mean by old bank. You're in a major city like Chicago or London, and you walk into that bank and it has the big Greek Doric columns on, right? And you walk up in and the marble floors glistening, and you walk into the teller and they're behind the iron bars to talk to them. And remember the old vault that was behind it? And if you say that's 1930 or 1940, if you asked them to design the bank of the future back then, you probably would have gotten a bigger vault, right? You probably would have gotten, you know, happier tellers, maybe a different kind of marble floor, but it all would have been thought in that kind of what I would call, in what's in the design world called functional fixation, because that's what a bank was. And we think about a bank today, right? That's a museum, right? Money moves around the globe at the speed of light. Every 20, we do our own banking at home, right? It's completely different in a way. And so I would say what designers always fight is how do you have a functional fixation on something? And if we just think of a hospital of the future as just four walls and what it does today, and tomorrow will be robotics, and tomorrow will be these exciting kind of things, that'll happen. But if we think of it just within those four walls and not think how miniaturization, information technology, how the speed of light and information changes things, we'll start to design in the wrong way and not design to embrace technology to how we're going to improve it, but just improve upon a model that I think is going to be somewhat obsolete going forward if we just consider it that way.
So here's a personal story. Recently I had about 21 of these tests, just for fun. I work on these tests, so I thought it'd be reasonable to experiment with some of them and get my own readings and try and make sense out of it. So many of my lab tests were low, which is good. Most were average, a few were high, and one was quite a bit high. All right, that's good. I just had a complete workup. I think we spent maybe $7,000 on it. There isn't a soul in the world who can tell me what all this means about my risk of cardiovascular disease. You cannot put it together. And I'm not insulting my physician. There's no way she could do it. I can't do it. No one else can do it. The reason is that all of these factors are related by very complex physiological pathways. This is the kind of diagram that physicians learn when they're in medical school and get updated on as technology changes and as science changes. This is just one particular pathway. It's the production of cholesterol in the liver. You can see the orange words are statins and bisphosphonates. Those are different treatments. They affect different pathways. So every one of these arrows represents a biochemical equation that's going on in your liver, frankly, right now. There are dozens, scores of these that are brought to bear on cardiovascular disease and all of the various risk factors. And it's absolutely impossible for anyone to see through all of that information, understand all of those pathways in a quantitative way, which is what you have to do in order to come up with someone's risk or the effect of a treatment. Just to show you how difficult it can be, I'm going to give you all a little test. I'm going to create for you the simplest of all possible pathways, and we'll see how well you do. Here it is. You go to the store and you buy 27 pencils. You pay 34 cents each. What do you pay? Anyone? No. How in the world do we think that we can capture all of the information about all of these tests, integrate them in the proper fashion? I don't know the answer to this. If someone has a calculator, you can go to it. I have a PhD in mathematics. It exceeds the human mind. Now, if I told you 10 pencils at 34 cents each, you would have all said $3.40. So the capability of the human mind lies somewhere between multiplying 34 by 10, we can do that, or multiplying 34 by 27. We can't do that. So the problem is that doctors are human too. They can't do this any better than the rest of us can. I should pause for a moment and ask if any doctors want to challenge that statement. In which case, I'll ask you to multiply 27 times 34. We can't do it. So how in the world are we going to master all of these different pathways? Now let's look at how we actually deal with the complexity. Saying that it's complex doesn't make the problem go away. We do live in a world where all of these issues come up. We simplify. We simplify right and left. I'll say we simplify grossly in medical decision making. Here's an example. This is a guideline for hypertension. It's designed by the best experts in the world, really. It's done by the Joint National Committee. It's the 7th edition. The guideline itself says